briefly describe in the next 20 minutes or so the journey we've been through together over the past 10 years or so. We all know that venous thromboembolism is a very important and common condition affecting between 1 and 2 per thousand of the population, and nearly half those cases, if not more, can be attributable to being in hospital, whether for surgery or with an acute medical illness. And we also know from many thromboprophylaxis studies that 50 to 60% of those cases of venous thromboembolism and the deaths are preventable. So this is a slide which is probably familiar to several of you in the audience. That the journey started back in 2004, 2005. There's a legendary sandwich lunch that if you grab hold of Beverly outside, she'll be able to kind of fill in more about between several committed clinicians. Beverly, AJ Keika, John Passy met with John Smith, and as a result the Health Select Committee was persuaded to look at venous thromboembolism as a problem. And then the kind of response of the government was invited shortly after. Again, I see in the audience some of the authors of that government response, particularly Tim Brown, who was then in the medical directorate in the Department of Health and working with Bruce at the time, and also Mary Newman, who was head of strategy at the time and is now head of strategy in NHS improvement. So that's when things took off. As a result, there were various committees convened by the chief medical officer, and as Bruce so eloquently described, there was a slow movement towards change, towards putting together common guidelines and common risk assessment tool, and setting the stage for what was to come next. And really, I think without any doubt, the game changer was that leadership summit at which these questions were asked to Sir Bruce, and in his very typical and forthright style. They always say that be careful what you wish for, because he managed to make a very challenging risk assessment target reality. And within months, people had to go from not risk assessing at all to a 90% risk assessment target. And again, we have been very fortunate in VTE in that we've been the forerunners of the use of these very powerful system levers, whether it was being the first sequent target, we were also the first quality standard for NICE. So we have benefited from that very enlightened approach in the medical directorate of the Department of Health at that time. So in 2010, Sir Bruce formally named prevention of venous thromboembolism as the top clinical priority for hospitals in England, and then things really took off. We had agreed, again for the first time anywhere in the world, there was agreement on a uniform risk assessment tool that was linked to a standard NICE guidance on VTE prevention. And suddenly, with these system levers and tools at our disposal, VTE found itself at the heart of the quality framework, whether it was the NICE quality standards for VTE prevention, whether it was this very challenging sequence. We were also in the NHS Litigation Authority risk management standard. And the leadership to this process, I think, was provided, no doubt, by the professions, together with the charities. We'll hear from Beverly, who's led the institution of Lifeblood at the time, which has subsequently been transformed into Thrombosis UK, and working together with the parliamentarians in the guise of the all-party parliamentary thrombosis group, who really were a force for good for VTE prevention at that time and since. Coupled with the energy and drive of the champions from within the NHS, exemplified by the National VTE Exemplar Centres Network. So NICE, for the first time, were in the business of not only producing guidelines, but also defining and benchmarking what best practice should look like. These are the quality standards which still apply to us now, that all patients need to be risk assessed and be given information, both verbally and in a written form, about their risk of VTE, and then really linking to the raison d'etre for the whole process, which is the administration of thromboprophylaxis as appropriate. We put in a lot of effort over the years to put the patient at the heart of the process, whether it was agreeing on a common patient information leaflet for the NHS in England, which again has been translated in about 10 different languages. Again, Sir Bruce was instrumental in helping set up NHS Choices at that time. And we filmed Paul Robinson, who was an ex-England goalkeeper, who unfortunately developed pulmonary embolism after spinal surgery and when he did not get adequate prophylaxis. So really putting the patient at the center of the process, involving them in the awareness and the decision making around VTE prevention has been key to the success. And indeed, there was an international survey of how well informed the public are in different parts of the world, and the public in England and the UK came out on top of that survey. And the work of Thrombosis UK we'll hear about from Beverly, and the all-party thrombosis group, all working in partnership towards, as Sir Bruce described, the common cause of VTE prevention. Education has been a big focus, both of patients and of healthcare personnel. Again, we have put together these educational training modules. The first of them was authored by my colleague Dr. Lara Roberts, which was aimed at secondary care. And we know that now has been completed by over 50,000 professionals who have completed the modules as part of the mandatory training and printed out the certificates. Since then, members of our team at King's have also contributed to producing 3 further e-modules. Dr. Julia Shaprinska, also in the audience, and Dr. Jake Patel have contributed towards e-modules targeting primary care and the commissioners. And then we kind of stripped all the politics out of it, and we've got a module specifically aimed at undergraduates, focusing on the physiology and the management of venous thromboembolism. So really, education is absolutely key to the success of VTE prevention. So to summarize this bit of the talk, we've come up with a comprehensive and systematic approach enabled by the levers provided by the NHS, and this has delivered over 95% risk assessment. But VTE prevention is perhaps unusual in quality improvement, that it started off due to a championing of the process by the believers, but we had no knowledge of the real world outcomes. So we've almost had to do this in reverse to look at the impact on the outcomes. And there's many limitations to this process, whether it's the fact that prophylaxis will only prevent half the clots. We know about the limitations of coding and death reporting, and also of the number of cases of VTE as an outcomes indicator. Because it depends on how you look and how hard you look and how interested you are in quality. So in the American Surgical Care Improvement Program, ironically, the hospitals with the best VTE prevention ended up with the most cases. So I think we have to be careful about how we interpret the data. As Bruce mentioned, now the risk assessment rates across the board in the NHS are over 95%, which is a huge, huge achievement on the part of colleagues in the NHS, considering there's 1 million admissions per month. and the admissions have gone up 25% in the past 5 years. We know as a consequence of actions, the prophylaxis has gone up by about 30%. This is an interesting graph. I'd mentioned we had over 50,000 completions of our first e-training module. But again, the seasonality of the training is of interest. You'll see that the 8th month, which is August, when the junior doctors start, we can see the peak in August and September. So these are recent figures from Health Education England. And Beverly published at the outset, after the first year of the program, a paper showing a 9% reduction in all cases of venous thromboembolism nationally. And then Domenico Pagano's group in Birmingham linked this improvement to achievement of the 90% risk assessment target. And we also published a study from King's showing that comprehensive VTE prevention program resulted in a 12% reduction in cases of hospital-associated thrombosis. Again, this was an interesting process because suddenly when you start looking for the cases, the figures can seem alarming. When we started identifying the cases of hospital-associated thrombosis, we found we had 20 cases of HAT each month and 1 or 2 deaths due to HAT each month. And these figures are very compelling. Then we decided to look at creating a national outcomes framework indicator relating to venous thromboembolism. And again, you'll notice that initially the figures seem to have gone up. And I felt we've really created a rod for our own back because we were so successful with the awareness work, and there's also payment by results was coming in, improving the coding. And we know that our NHS population is now getting older and sicker. But I'm pleased to say that in subsequent years the figures have come down, kind of demonstrating an 11% reduction in post-discharge VTE deaths since the advent of the VTE program, which to my mind is a very, very considerable achievement. So in summary, as we aspired for many years ago, VTE risk assessment has become business as usual in the NHS and embedded in everyday care. It is acknowledged as a patient safety priority, and there's evidence of improved outcomes at a national and local level. So it's job done. Or not quite. One more slide to come. However, a substantial burden of disease remains. The majority of cases we see in centers of excellence like King's would be due to failure of gold standard prophylaxis. But in the rest of the country, I'm afraid many hospitals have not progressed beyond the kind of financial incentive-driven kind of risk assessment target. And they're not auditing appropriate prophylaxis, nor are they doing root cause analysis as mandated in the National Acute Care contract. And of course, we are competing with many other patient safety priorities. And this is some data from Plymouth, in which kind of they demonstrated after the initial improvement, a kind of leveling off of the number of cases of hospital-associated thrombosis. So I think to go forward, we need to better understand the risk profile in these cases of thromboprophylaxis failure, to devise better thromboprophylactic strategies. And lastly, Sir Bruce wanted one line from me on where we go next. We've been working with HQIP for a couple of years now to persuade them to include VTE prevention as a national clinical audit. And they agreed as part of this to fund a feasibility study looking at this, which we've homed in the South London Health Innovation Network, and I'm the clinical lead for this study. And we are due to report shortly at the end of the year at the feasibility, the specific improvement aims, what tool we'll use, and what patient group we target. But I know from attending the patient safety committees and the national board as well, that the national clinical audits really are very powerful tools to help drive change as well as to support quality at the highest level. So I think, I hope I've demonstrated the kind of comprehensive systems-based approach we've devised, and Sir Bruce has been very much the architect of that vision. But going forward, sustaining and improving this best practice is going to be a continuing challenge for us all. Thank you. I'll stop at that.